Sushmita, and thanks for that introduction. Everybody is very kind to me in the GSI, and I'm very, very fortunate for that. Well, good afternoon. We'll now talk of bleb needling after we've discussed how to identify early and late failures, and we'll just do an overview of when we resort to it and how, and the use of antimetabolites. There are no financial disclosures to this talk. So we'll look at bleb failure, when would we resort to needling, the characteristics, clinical evaluation, and in additional, most of it has been done, but I'll just stick to some points to keep in mind before doing a needling, because there are other things that you can do when the bleb fails. Then we'll see a little bit about the procedure and then the adjuncts that we can use. So as Dr. Mayuri time and again reiterated, the failure could be because of an intraocular process, so you need to look at your sclerostomies. It could be intrascleral, which means the scleral flap has sort of flattened, and it could be subconjunctival, which could be due to episcleral and tenon-conjunctival interface. So common sense tells us that it's only the third one that doing a subtenon's needling would help. If you have a blockage intraocular or you have a blockage in the sclera, then just needling a subconjunctival space is not going to happen or work. And that's the reason why you've got to evaluate these blebs and decide on which are the cases which require needling. And how does it work? It works by disrupting the subconjunctival fibrosis and restoring the bleb space. So this method of re-establishing filtration have very variable results, and I suspect we have variable results because these blebs were needled regardless of what the cause was, and that's why we have reports, and I've just put them down, from 91% success with a mean follow-up of 9 months to 80% after an average of 2.5 needlings. So an average of 2.6 needle revisions and a success rate of 59% when you looked at them a year later. So why are they so variable? Because intra-bleb morphology is so difficult to assess clinically. So you don't really know, as Dr. Mayuri said, what's happening underneath what you're seeing on the sclera. And it's essentially a blind procedure, and more importantly, the status of filtration under the scleral flap is not known. So if you're going to needle just under the surface of the conjunctiva, it's going to be a little difficult. So this was what we did, and it's funny to say almost 20 years ago. It's been so long since we did our PGs, but type 1, 2, 3 and 4, despite all the new classifications that has come, this is, I find, the easiest clinically. So it's just, if you remember that a type 1 and 2 bleb are functional and type 3 and 4 blebs are non-functional. So this is a typical example of a thin polycystic bleb, a flat, diffuse, relatively avascular. This is a prototype trab. If you get a bleb like this, you're done. There's nothing else that you need to do. But this, as all us glaucoma surgeons know, is many times when we get very, very lucky. A type 3 is a flat appearing bleb with subconjunctival fibrosis and engorged vessels on the surface, and type 4 is an encapsulated bleb, which is here. It's localized, dome-shaped, hypertrophied, and the type 3 and 4 do not function, and the type 1 and 2 function. So just take a bit to look at these blebs and put them in your head that if you see morphological blebs like the first two, they're likely to be functional, and the last two are likely to be not. So, to ensure that your needling has a good procedure or a good result, what's best is to do it in a type 3 bleb. And it's obvious, a type 3 bleb will be the one which will be amenable to a subconjunctival disruption of tissue. If you're going to try that in a tenon cyst, you're not going to be able to needle and not going to be able to do much. The second thing you need to be very, very careful about is that it has to be an open sclerostomy. I would talk about the UBM because I have access to it, yes, but one very good clue is to see that the internal ostium is fish mouthing. And what I mean by that is, look at it, if it's a little open, like a fish mouth, it's likely that there is aqueous percolating. But if on gonioscopy, even if it is not blocked by the iris or uvea, if it is closed, flat, then it's most likely that there is no aqueous flowing into that scleral flap. And if there's no aqueous getting out of the eye into the scleral flap, unless you raise that scleral flap during your needling, which has also been described, it's not going to work. So be very careful in your clinical examination, and these are all examples of fish mouthing. This is a large fish mouth. You can be sure that this needling is going to work. This is another one, and then this is another one. So if your internal sclerostomies are open and they fish mouth, it's a good clue that probably your needles are going to work. It's unlikely to work in a tenon cyst if you have a blocked sclerostomy and in a hypertensive phase. We'll just touch upon a hypertensive phase at about 6 weeks of time. Usually this is too much of a good thing. Too much of aqueous goes out of the eye. The microcysts underneath the conjunctiva flatten out, they don't leave the eye, and the bleb gets bigger and bigger. It's important at 6 weeks to recognize a hypertensive phase, because contrary to what is taught, all you need to do is reduce aqueous production. You give them aqueous suppressants for 2 to 3 weeks and the bleb settles down, and you could avoid landing into a tenon cyst. But those are all careful procedures and careful observations of the bleb. So can we look inside? I don't have the ASOCT as yet, but we have tried to look inside using the UBM, and we just tried to look at the structure inside the filtrant bleb. The most important thing that we realize is if this route is patent, because I don't like to blindly go under the scleral flap and enter the eye with the needling procedure alone. So we basically do a subconjunctival needling, and if this scleral route is occluded, then the needling is definitely not going to work. So the UBM classification of blebs have been there for a long time now. So these are just what Yamamoto's group has described. But more than the blebs, what we at PGI look at is, like I said, whether the scleral route is patent or the scleral route is occluded, and that's the only one thing that we learn. Because once we decide that it's a fibrous bleb which is not working, it doesn't really matter how many microcysts there are in the bleb or whether or not there are too many of them. So to summarize this, all that we did was we took all our type 3 blebs and we did a UBM in all of them and needled all of them just to see knowing whether or not the scleral route was occluded or patent made any difference to the result. And the presence of fluid under the scleral flap, as common sense we thought, did correlate with success. So this is just a quick 1-minute video of what we do. We like to do it under the microscope because I think it's more controlled and the patient is under anesthesia and lying flat. The slit lamp can get to be very traumatic. It's very difficult for a patient to keep looking down when somebody is poking a needle in the superior part of his eye. So we do it. This is the type 3 fibrous bleb that I showed you. We enter away from the bleb so that there is no leakage later. And then you can see I use a 26 gauge needle. It has been described with a 27 and 28, but what I've noticed is many times that it's to be too thin and malleable, and many times it doesn't give you enough purchase to cut the scleral tissue. With the bevel of the needle up, the sharp edges just cuts through the subconjunctival fibrosis. And in the OT, you can actually hear it go kadak, 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 kadak. So this is what I tell the PGs, can you hear that? So if they stop talking and chatting, they can hear. You can hear the fibrous capsule really be excised. So now if you see this slowly, you see this is getting more transparent and the fluid is started to percolate out. So you can actually see the fluid coming out into a bleb. Can you see it raised a little bit? So you know that you're going all right. But remember this, we've ensured on the gonioscopy that the sclerostomy not only is open, but it's also fish mouthing. So we're sure that there is fluid under the scleral flap and we don't want it. I don't like this bleeding, but somehow it is inevitable when you needle, because when you're disrupting scar tissue, it does tend to bleed. But at times you just have to live with that. So you just carry on. There's no rocket science to this procedure. You just carry on, and it takes a lot of patience. It's very annoying to just keep fiddling under the conjunctiva, waiting until the bleb forms. But that is the end point really. You need to wait until the bleb forms, and the globe does soften, and you know that you've restored filtration, and then you go ahead. So this is the end point, and this is the same patient. Post needling, you can see the fluid here. So you know that, and this is what he was like with a patent scleral root and absolutely hyper reflective. the first few things are coming, and here at the end of 3 weeks you have a nice big cyst there. So you know that you've restored filtration. Where there is the scleral root is occluded, this is an example where it was absolutely occluded. We did the needling 1 month, 6 months, it has made no difference whatsoever to the bleb, commonsensically, because there was no fluid that was going out of the eye in the first place. So, blebs with scleral root patent on UBM appear to have more chance of success. What about antimetabolites? I'll just wind up with this. Always at the end of procedure and away from the bleb area. This is where I usually inject it. Way off so that it percolates diffusely. Be very careful at the end of the procedure. Remember, you have a soft globe. You've restored filtration. If you're going to put it in the bleb area, you're going to be in a lot of trouble. The dose that I use is 5 milligram, 0.1 cc. It's the easiest thing on earth because flyfluorouracil is available in this percentage. It's available as 250 milligram and 5 cc, so that's 50 milligram per cc. So you just take 0.1 of that and you're in. You don't need to do any dilution. You don't need to do anything at all. But be careful. And I put this case up, and this is a stupid thing that I did once, but this is on the slit lamp where I've injected 5FU in a patient with low pressure and after a suture removal. And this is what happened immediately. It went absolutely white in the center, and this is what happened to the cornea. I was sure he would be landing up with a PK. 1 week later, he had this horrible epithelial defect, and this is what his cornea looked like. And maybe a month later, it had started clearing. We had our hands in our mouth, so to say, but finally 6 weeks later, he did clear. This is what he was like. This is what he started off with at the end of the procedure. So you do get your heart attacks, but in case your 5FU does go in and you recognize it has gone in, just come out and just hold on. There's no need to panic. They do clear. Thankfully, in this case, it did. So to summarize, a clinical evaluation before taking a decision to needle or revise a bleb is mandatory. Judicious patient selection may hold the key to the success procedure, and UBM may be a useful tool in this decision making to avoid unnecessary. Thank you.
Thank you, Sushmita.